the wireless eye clearscope device, which is the instrumentation that we're using to visualize the ear and record this procedure. So client number one, so we're in the patient's right ear at the moment, and you can see that the patient has soft and wet wax. That's as a result of the patient using some olive oil drops prior to attending the appointment. She did have quite a bad blockage when she contacted me over the phone, and I said if she would want to, she's more than happy to use drops prior to attending. Typically, if patients want to book in with myself, even if they do have really hard earwax, I'm more than happy to see them the same day. The patient felt they've had wax removed before, you see, elsewhere, and they found that olive oils always helped them. So you can see the patient's ear anatomy here. She's got quite an inclined ear canal. So the ear canal kind of slopes upwards here at the moment, a bit like a mountain slope, and that's a possible reason as to why the patient's getting a regular build-up of earwax. As the wax is trying to migrate, it's getting trapped down the valley, so to speak. So the ear canal goes down and it slopes back up again, so it creates a V-shaped alley where the wax can lodge. Nonetheless, we remove the wax, there's a tympanic membrane, it's fully visible. I'm just going to go back in, just mop up just a bit of wax on the anterior canal wall. So with our technique, when we're using microsuction and dry instruments, there is no prerequisite to use softening earwax drops prior to the appointment. If you're having your ears irrigated or syringed, then typically you are requested to soften that earwax for 10 days, or 10 to 14 days even. During that time, however, if you're a hearing aid wearer, for the fortnight you're using the drops, it's going to possibly interfere with your hearing aid, blocking the sound bores, so the sound won't come through. And when you use drops, the wax actually absorbs the drops and it expands and swells and creates more of a blockage, and therefore exacerbates your symptoms. And in the case of specifically wearing a hearing aid, a buildup of wax can cause the hearing aid to whistle. So the sound that's amplified into the ear via the hearing aid bounces back off the wax, re-enters the hearing aid microphone, causing acoustic feedback or feedback loop. So that's one of the benefits of having your ears removed via dry instrumentation, whether it be microsuction or a ear hook or Jobson horn or crocodile forceps. So it's the same patient, just her left ear. She didn't use drops on this side because if she used drops on both sides, it can completely block both ears, so she's not able to hear at all from either ear. So the patient just wanted to use the drops in one ear, but as she was here, I said I'm pretty sure we can remove this. So we decided to give the left ear a go. So as you can see, it's not soft, so it's a bit more resistance. The ear canal is slightly more twisty on this side, so this wax is lodged around the bend. So we're looking straight. If you look at the moment, we've got the angle of the endoscope straight into the ear canal, and if I was to go any further in a direct line, the tip of the endoscope would hit the back ear canal wall. So just where the suction probe is, you can see the first bend of the ear canal. You can see the cartilage, and then it bends off to the left. So the patient has got quite a prominent first bend of her ear canal. So we're just manoeuvring this wax around that bend. And now we're just trying to straighten it. So I've got it around the bend, but I have to bring it back towards the left now so it comes out of the ear canal. Just trying to get a suction grip. The patient has got a lot of matted hair on the lateral surface. So when we say lateral, we mean towards the entrance, closer to me. And you can see where the suction probe is. There's a bit of matted hair, which piece came out up at the suction probe. So I'm just trying to wriggle this out. So there's that first prominent bend of her ear, then we straighten the endoscope to visualise the eardrum, and that looks nice and healthy. Just going back in to mop up around the entrance. So this is client number 2. It's the patient's left ear, and the patient has got, I would describe as being dry and crumbly earwax and a bit of keratin. Again, the patient had been using some drops prior to attending, that's why it's a bit wet and lubricated. So I removed a piece of dead keratin and a bit of dry wax on the roof of the ear canal. We're just now at the base, so you can see the cilia. So the cilia are the hair follicles, and you generally find the cilia and the hair follicles in the outer third of the ear canal, so the first centimetre. The outer third of the ear canal is made up of cartilage, some fatty tissue, some muscle, and hair strands, hair follicles. And it's the outer third of the ear canal that secretes the earwax. So the ceremonous glands, the sweat glands, and the sebaceous glands, which secrete a substance called sebum. Those two glands, in conjunction with dead skin, all the byproducts of that amalgamates together and creates what we know as earwax, cerumen. So I've cleared the blockage. I'm just going to mop up. I've just got the fine end gauge, just a piece of dry wax and some dead keratin at the base of the ear canal, which we're using a fine end to delicately and gently suction that. And there's the patient's tympanic membrane, nice and healthy. So it's the same patient, just in the right ear. And again, the patient's got very dry, crumbly wax and dead keratin. They, once more, hadn't been using any drops in this ear, so there's no lubrication. It's very dry indeed. So it's just trying to get a suction grip. When you've got dry earwax, and the patient's ear canal is also quite dry, that friction, so as the wax is trying to migrate out of the ear, because it's really dry, it's rubbing against the side of the ear canal, and the migration route of the wax is halted. The patient also has got quite a narrow ear canal entrance, it's quite slit, so another reason for this patient developing earwax buildup, which we medically know as ceremoniasis, that's the name given to earwax impaction, is because the wax is getting lodged and trapped near the entrance of the ear canal because it narrows. So I'm just trying to loosen this plug of dry wax off the base of the ear canal. I have a feeling also the patient had been using a bit of cotton bud, cotton swab or Q-tip, because just here at the entrance of the ear where the wax is, you can see it's a bit white here, so it looks like some cottonwood fibres. So I've decided to use some forceps. I inserted them vertically because the ear is very narrow, managed to grip onto the lateral edge of the wax, pulled half of it out, the other half got lodged at the entrance because it was so narrow it got trapped. So again, it kind of highlights a possible reason why the patient does get wax buildup, because in the same way the wax got trapped near the entrance as I was trying to pull the wax through using the forceps, as the wax is naturally trying to migrate out of the ear, she can similarly have that issue. So just some dead keratin on the anterior canal wall near the entrance. You can see the skin's a bit scaly here, so she has got a bit of otitis externa. Otitis externa is an umbrella name for an infection or inflammation of the outer ear canal. And again, just using the fine end gauge just to lift and elevate some dead keratin, some dead skin off the base of the ear canals. But we're quite deep in the ear canal there on the bony part, so we have to be very gentle to ensure we're not making direct contact with the bony part of the ear canal, because that's very sensitive indeed. And managed to weigh the contents of this patient's ear, and it came in at 373 milligrams. So here we have client number 3. Again, we're starting off with the left ear. It's a large plug of soft-ish earwax, I would describe it as. So earwax can be categorized as either being dry or wet, but there are subcategories underneath each type of wax. So you can see the patient's ear anatomy at the base of the ear canal is quite a bony protrusion there, which means the patient's got a very deep inferior recess. So again, that could be a reason for the patient's buildup of wax. When you've got ridges and little divots or trenches or canyons in the ear canal, it can cause the wax to collect within that widening or narrowing of the ear canal. Sometimes if there's a really deep and wide erosion or opening of the ear canal, the patient can undergo some sort of surgery where they use some fatty tissue to fill up that indentation, that dent, just to allow the natural migration of skin and earwax out of the ear. So same patient just on the right side, so you can see that we know we're near the entrance because of all the hairs. The hairs, as I mentioned previously, are always located on the outer third of the ear canal. You don't find cilia, which is the medical name for these hairs, in the inner 2/3 of the ear canal. So the inner 2/3 is just a very thin sheet layer of skin measuring 0.1 millimeters in thickness, coating the bony part of the ear canal. So that's non-flexible and very sensitive if you make contact with that part of the ear canal. The outer third of the ear canal is cartilage, some muscle and some fatty tissue, and it's a thick layer of skin which measures around 1 millimeter in thickness. So it's 1/10 thicker. Sorry, 10 times thicker, should I say, than the skin that coats the inner two parts of the ear canal. So there's more give, the outer part of the ear canal is more pliable. So I'm just trying to wriggle this through because the patient has got, again, a very narrow ear canal entrance. And as I'm wriggling this forwards, towards me and out of the ear, I'm always at the same time having to manipulate the angle. I'm now extracting it forwards but towards the right hand side, so that's the natural curvature of the ear canal entrance. You can just see how narrow it is as well. You can see how much force I'm putting whilst I'm tugging this wax out of the ear. And you can see the angle of wax, it's almost coming out at an angle of, I would say about 125 degrees really. So I'm pulling it not only towards me but to the right hand side. So this patient's got a very prominent first bend of her ear canal and a very narrow ear canal entrance, and more than likely that's the cause for their wax buildup. The wax is trying to migrate outwards but it's getting trapped around the bend, and as it approaches the entrance of the ear canal, as it's narrow, it just gets trapped and you get a natural buildup of wax behind it. Nearly there. Part of me, this procedure's probably a month old, but I could have put the suction probe down, got the ear hook and gone in, but you always felt it's going to come out anyway, so by the time you put the suction probe down, switch the suction machine off, get the ear hook, you've probably got the wax out anyway. You see how dry it is, this ear wax, and there we are, just extracted a big lump of wax there. The eardrum's fully visible. Patient may have had a previous heel perforation anteriorly to the front of the eardrum. You might get another glimpse, but there's a bit of a thinning of the eardrum there. So some dead keratin near the entrance and on the rear ear canal wall and just at the roof of the ear canal. But just to the right, you may have seen that. And again, managed to weigh the contents of the patient's ears in at 346 milligrams. So this is client number 4. Patient attended, had used a cotton bud, a Q-tip, a cotton swab, impacted against the eardrum. You can just see here how narrow the ear canal entrance is. It was virtually shut, and I used the tip of the Zollner suction probe to widen the ear canal, stretch it open, and once I did, I was able to insert the endoscope in. When we first launched endoscopic earwax removal in the UK, the status quo, people who were using different techniques, who were adverse to change, said that with an endoscope you can't use it in a narrow or twisty ear. And well, I won't talk too much about it because I don't think they would like it, but there was a governance board that wrote some guidelines, and they're being very scrutinous about endoscopic earwax removal, and myself and my colleague Mr. Dirtiest challenged this organisation, and in the end we had them apologise and rewrite the guidelines and procedures because they didn't have any knowledge themselves of an endoscope. So yeah, one of the for the status quo at first, who obviously adverse to change, weren't liking new technology. That happens, I'm sure, across healthcare. They were criticising endoscopic earwax removal because you say, oh, you can't open the ear. What would you do if the ear is narrow? And what's great about our technique is that we can record the procedure and show the doubt as well. Okay, well, this is the narrow ear, it's as narrow as it gets. The ear canal's virtually shut at the entrance, and it is possible because I've recorded it and I can show you. So, but yeah, it is a skillful technique. You just can't pick up an endoscope and start treating people's ears. So we have a lot of people who attend our training courses that perform earwax removal already using a different visualization technique, either it being an operating microscope or head loops. So head loops like goggles, similar to what dentists use, and you may be very proficient in using a microscope or head loops. So that doesn't mean you're all got the required skills to perform endoscopic earwax removal, and vice versa. If I'm obviously very proficient in using an endoscope, but when I got taught how to use a microscope by my colleague Mr. Rajali, it did take me a while because it is a different technique. Your eyes have to adjust and set in a different way. We use binocular vision, stereoscopic vision with a microscope, which you don't using an endoscope, because with an endoscope you're visualizing the ear on a flat 2D screen. So it took me a bit of practice, but after using both an endoscope and microscope and head loops, for me there's just no comparison. You just simply do not get this same view with either a microscope or a head loops with an endoscope. And why endoscopic surgery is on an exponential increase, especially in the UK, not only, particularly within ENT actually, is because of the view it provides. An endoscope provides an unparalleled wide panoramic field of view. You can see everything. You go in the ear, you feel like you're inside the ear and you're kind of trapped inside yourself. With a microscope or head loops, the view is very narrowed. The advantage of a microscope is that you get great magnification, which you cannot get with head loops. No matter how good your head loops are, they simply do not possess the same magnification qualities as an operating microscope. The last client is a very quick short video, but it's one of my favourites. I really enjoy when I remove wax or keratin off the eardrum. This patient had been elsewhere and they were told that there's nothing wrong. I can partly understand the audiologist explaining to the patient that there was nothing wrong, because sometimes a bit of residual wax or keratin on the eardrum doesn't really cause any symptoms, but that can